In this presentation, we present a Western population-based cohort study on oncologic outcomes of laparoscopic versus open gastrectomy for gastric cancer using the National Cancer Database. I have no disclosures for this presentation. First, we will discuss background and existing literature on the advantages and disadvantages of laparoscopic versus open gastrectomy for gastric adenocarcinoma, followed by the primary objective of the study, the methods including data acquisition and statistical analysis, the results regarding both short-term and oncologic outcomes, and finally the conclusion of the work and its role in framing guidelines for the management of gastric cancer. Prior studies have shown improved morbidity for laparoscopic gastrectomy compared to open gastrectomy, such as reduced complication rates, faster time to oral intake and ambulation, less analgesic requirement, reduced intraoperative blood loss, and shorter length of hospital stay, which extend even to at-risk populations such as the elderly, cirrhotics, and following neoadjuvant chemotherapy. Despite encouraging reports, findings are not consistent. Thus, laparoscopic gastrectomy has also been associated with longer operative times, worse rates of anastomotic leak and stenosis, pancreatitis, pancreatic fistula, bleeding, and reoperation. Currently, it remains unclear whether oncologic outcomes may benefit from a minimally invasive approach. Randomized controlled trials have demonstrated equivalent 5-year overall and disease-free survival, but have limitations such as single institution design, small cohort size, inconsistent follow-up, or limited extensive gastrectomy performed. Furthermore, reports of quality of oncologic surgery for laparoscopic versus open gastrectomy are inconsistent, with some showing improved lymph node harvest, rates of D2 lymphadenectomy, positive margin rate, and completion of adjuvant chemotherapy in a laparoscopic approach, while others show improved extent of lymph node dissection and lymph node yield in an open approach. Further, laparoscopic gastrectomy may only be oncologically safe and effective in specific settings, such as high-volume academic centers. Moreover, many reports are from Eastern centers, which may have differences in tumor biology, operative experience, or earlier stage of diagnosis due to screening programs. Additionally, past studies rarely report short-term mortality and the readmission rate differences in a comparative fashion. Therefore, our objective is to compare not only the short-term outcomes, including hospital stay, readmission, 30 and 90-day mortality, but also oncologic outcomes of nodal yield, margin status, and survival of laparoscopic versus open gastrectomy. The National Cancer Database was used as the data source with selected time frame from 2010 through 2016, as 2010 was when surgical approach for gastrectomy was first documented. Inclusion criteria were adult patients with histologically proven M0 gastric adenocarcinoma with complete clinical, procedural, institutional, and survival information. A custom computer script was developed to check for discrepancy in the NCDB records. Binary logistic regression models were used to evaluate the impact of surgical approach on perioperative outcomes, including 30-day mortality, 90-day mortality, margin status, and unplanned 30-day readmission, whereas linear regression models were used to evaluate the impact of approach on lymph node yield and hospital stay. Kaplan-Meier survival analyses and log-rank tests were performed to analyze the impact of approach on survival, and Cox multivariable regression models were constructed to identify factors affecting survival and to correct for any confounders identified. The NCDB query identified 13,538 patients fitting the inclusion criteria. 3,170 underwent laparoscopic gastrectomy, while 10,368 underwent open gastrectomy. Mean age was 68.1 years and was similar between approaches. Prior to adjustment, laparoscopic and open cohorts had significant differences in the factors of sex, T stage, tumor size, end stage, as well as nodal yield, type of surgery, positive margins, unplanned 30-day readmission, 30-day mortality, 90-day mortality, facility type, and hospital length of stay. 30-day mortality for the entire cohort was 3.5%, 2.5% for the laparoscopic group, and 4.4% for the open group. 90-day mortality was 6.7% for the entire cohort, which broke down to 4.9% for the laparoscopic group and 7.3% for the open group. After correcting for confounders, no difference was seen between surgical approaches for 30-day mortality and 90-day mortality. No difference was also observed in margin positivity by laparoscopic versus open approach. Linear regression analysis showed a significant equation favoring laparoscopic gastrectomy for both lymph node yield and hospital length of stay. Logistic regression analysis demonstrated unplanned 30-day readmission rate was significantly improved in the laparoscopic gastrectomy group. A Cox multivariate regression hazard model for factors affecting survival revealed that age, male sex, greater than or equal to 2 comorbidities, as well as grade greater than or equal to 3, T-stage greater than or equal to 2, tumor size, end-stage X or greater than or equal to 1, total or proximal gastrectomy compared to distal, positive margins, and increased hospital stay were all associated with worse survival. Conversely, surgical management at an academic institution compared to at a community hospital and adjuvant chemotherapy were both associated with better survival in our Cox multivariate regression analysis. Kaplan-Meier's survival analysis showed mean overall survival of 43.8 months for the entire cohort, with 44.8 months in the laparoscopic group and 40.2 months in the open group. A significant difference was seen between these surgical approaches. However, after correcting for confounders through Cox regression analysis, no difference in overall survival was seen between laparoscopic and open gastrectomy. In conclusion, a laparoscopic approach to gastric cancer resection was not statistically different from an open approach in negative margin rates, 30-day mortality, 90-day mortality, and overall survival. However, laparoscopic approach was significantly superior to an open approach regarding hospital stay, readmission rates, and lymph node yield. Regardless of approach, age, male sex, greater than or equal to 2 comorbidities, grade greater than or equal to 3, T-stage greater than or equal to 2, end-stage X or greater than or equal to 1, total or proximal gastrectomy, positive margins, and prolonged hospital stay were all associated with worse survival, whereas academic institutions and adjuvant chemotherapy conferred better survival. Although no definitive guideline for laparoscopic versus open approach exists, laparoscopic gastrectomies improved nodal yield and similar survival may better meet surgical standards for higher quality resections as outlined in NCCN guidelines. Therefore, laparoscopic gastrectomy offers a safe surgical approach to gastric cancer with benefits of shorter hospital stay, lower readmission rates, and improved lymph node yield while maintaining similar surgical oncologic safety and survival. Thank you for listening.